Hi everyone, I'm glad to welcome you all. I'm Chaitra, the moderator for today's CellTalk webinar. Today's CellTalk is being addressed by Dr. Bharati on the topic of somatostatin receptor Theranostics for refractory meningiomas. The Dr. Bharati is working as a clinical content ambassador in the Renex Life Sciences. Her areas of specialization include relief of immediate tooth pain. Due to her keen interest in the research field, she worked as a freelance writer associated with the various research projects at NTR University of Health Sciences. She completed her Master of Dental Surgery from Krishna Devaraya Dental College and Hospital, Bangalore in the year 2018, and her Bachelor of Dental Surgery from Government Dental College and Hospital, Vijayawada in the year 2013. She also did her intermediate schooling at Ratnam Residential School and College, Nellore. Apart from her post-graduation, she did oral implantology and basic life sciences courses. She also currently has 4 publications and 2 under pre-review. While she strives to work hard in this fast-paced and highly competitive environment without compromising on productivity, and at the same time, she would like to explore new skills and technologies in this research field to update her knowledge and improve her efficiency. So without further delay, I would like to invite Dr. Bharti to take over the session. Over to Bharti.
Yeah, thank you, Chitra, for your nice introduction. So, good evening, everyone. Welcome to our CellTalk presentation in Renex. So, my topic is somatostatin receptor Theranostics for refractory meningiomas. The original authors are Betty Salax, Thomas Grallian, Titania Horowitz, and Oliver et al. So this topic was selected for the meningioma, and the title of the journal is Current Oncology with the impact factor of 2.257, and it is published in the year 2022. This research, which was conducted, has an impact on the diagnosis of meningioma, and what are the different treatment options available in meningioma, and what is their success rate, and what is the treatment option that is used for the recurrent or refractory meningiomas. So without further delay, we will go into the topic. So what are meningiomas? They are nothing but the non-cancerous tumors which develops in the membranes that covers the brain and the spinal cord, that are meninges. So they are the most common primary intracranial tumors that exist in the adults. So apart from the anatomical location, clinically they are related to various clinical outcomes, and they contribute to about 30% of the primary brain tumors. So World Health Organization classifies 20% of meningiomas as high-grade meningiomas with recurrent activity, whereas that is which comes under H for grade 2 and 3, whereas the remaining 80% they're classified under grade 1 tumors that are benign with low recurrent activity. So what is somatostatin receptor? It is nothing but a synthetic analog of somatostatin, and it's a G protein coupled receptor. So why it is significant in meningioma? When we take any scan, or if you go through the molecular studies, somatostatin receptor is the common receptor that is widely expressed in meningiomas. So since it is commonly expressed in meningiomas, this is extensively used for the diagnosis and treatment of meningiomas as a diagnostic marker. So how do you know the uptake of somatostatin receptor? So either with the help of PET scan or CT scan, we will scan for the uptake of somatostatin receptor by a radioactive labeled by gallium-68. So this methodology has an increased role in the tumors which are having this somatostatin receptor expression. Not only meningiomas, all types of tumors that have the somatostatin receptor expression. So coming back to meningioma, what are the common treatment options that are available? Neurosurgical resection and radiation therapy. So according to the literature, the anticipated 5-year recurrence rates for grade 1, grade 2, and grade 3 meningiomas are 5%, 40%, and 80% respectively after the full resection of this meningioma. And again, what are all the factors that contribute to the likelihood of recurrence in this disease, or how much degree we are the resecting the tumor, and what is the tumor is localized or it has extended to the adjacent tissues, and what is the grade of the tumor, that whether it is high grade or low grade, and more recently Ka67 expression. It's an immunohistological marker which is actively present in meningiomas. So based on its expression, how much intake or how much percentage it is expressed in the meningiomas, it also helps to evaluate the recurrence of the disease. So what are the present challenges that we face in meningioma? So high-grade meningiomas, those are grade 2 and grade 3 meningiomas. They demonstrate aggressive behavior and they're characterized by the high recurrence rates, and they're resistant to the normal traditional treatments like surgery and radiotherapy. So in complex anatomical locations like cavernous sinus encroachment and all, their management will be slightly difficult, and patient will have a more chance of morbidity and mortality risk, and the treatment whatever we apply, it might be inadequate or incomplete to cure the disease completely. So whenever all these other treatment options are not feasible, or if these treatment options fail to cure the meningioma, whatever the systemic therapy we are applying, it won't give you any defined results, and it still becomes experimental. So these patients we should look into the new approaches to treat these patients. So one among them is peptide receptor radionuclide therapy, that is PRRT, which is gaining popularity in the field of neuroendocrine tumors. So, and it represents an attractive approach for the treatment of meningiomas. So what is PPRT? Nuclear therapy. It is similar to the radioactive nuclear therapy. Then why it is so much specific? Compared to the external nuclear therapy, it is very high specific on meningioma cells, and it will be able to deliver the radio session of radioactive nuclide on specifically on the meningioma cells. That is, it is more suitable for the meningioma cells. So what is the objective of this research? This present study will evaluate the overview of the efficacy of this peptide nuclear therapy with the radioactive tracer called 177 lithium dotatate. It is a chelated complex of a radioisotope of the element lithium with dotatate. This is a dotatate is an 8 amino acid compound which is having bifunctional groups. So for the treatment of refractory or progressive meningiomas. So it's a retrospective study that will it go back to the results and evaluate. So what it will evaluate is how much is the progression-free survival. That is, without progression of the meningiomas, after 6 months, what is the overall survival rate of the patients? And this study compare these findings to the already available data that is present in the literature, which was stratified according to the WHO grades, that is grade 1, 2, and 3. According to different authors, what is the data that is available according to the grades? That is, how much is the survival rate? So that data we will compare with this data. So the key term in this literature, in this study is Theranostics, which is nothing but the pairing of these diagnostic markers, that is the somatostatin receptors, with the therapeutic agents that share a specific target. So we are comparing these biomarkers which helps somatostatin receptor and with the PPRT, that is the peptide receptor nuclear therapy, and we're seeing how much efficient this is in treating the refractory meningiomas. So coming to the methodology, all the patients who received, first of all, the patient should have a progressive and resistant meningioma, and they should receive the radioactive nuclear treatment in France, a hospital called Latamena University Hospital between August 2019 and October 2021. All were these included in this retrospective research. So what are the inclusion criteria? I mean, which patients will receive this peptide radioactive nuclear therapy? First, they should have a progressive meningiomas. That is, the meningiomas are not treated by the conventional methods like surgery or radiotherapy. Second, before giving the treatment, if you scan them preoperatively with dotatate PET scans, they should have a somatostatin receptor positive uptake. Then only they are considered for the PRRT criteria. So exclusion criteria include the urine incontinence and lesions which will show the effect on brainstem, and if they have a hematological toxicity of either grade 3 or grade 4. So as I told first, before the beginning of the treatment, preoperatively first we will do a gallium data scan and see whether it has a somatostatin receptor intake. So after about an hour following this injection, we'll perform a whole body imaging with 2 to 3 m becquerel per kg. Then the radioactive for the PRRT therapy, we will apply DOTA-TAT with 177 luteum. So for diagnosis, we are using a radio tracer called gallium preoperatively. When we are giving the PRRT treatment, we are replacing this gallium with the luteum. So the treatment was given by the progressive intra-infused infusion over about in half an hour to 1.5 hours in cycles of no less than 3,200 m becquerel, that is megabecquerel, which is a measurement standard unit to measure the radioactive radiation that we are giving. And it shouldn't cross across between 7,400 m becquerel per cycle with a maximum of 4 cycles. So we cannot give more than 4 cycles in this study. And the gap between these two, each cycle should vary between 8 to 9 weeks apart. So along with this therapy, to protect the kidney from the radionuclide damage, the patient will be advised amino acid solution supplements, antiemetics, etc. So after this proton radioactive therapy, the patient will underwent an MRA. The MRA will be taken for every 2 weeks, and simultaneously with the MRA, a blood test will also be done to assess the functioning of liver, kidney, and hematological function. So in the clinical assessment, that is in the MRA will be evaluated by the neuro-oncologist to see that the patient is developing any motor or sensory impairments, and what is the size of the subcutaneous tumor masses, that is for every 2 weeks, or they're disappearing, or they're progressing, or they're stable. And if the patient gets any exophthalmos during this treatment, and what is the frequency of epileptic episodes, that is the patient is getting any epileptic episodes during this course of radioactive therapy. If they are getting, what is the frequency, and what is the dosage of corticosteroids that are administered. So coming to the results, these are the patient characteristics that were included in the study. So the median age of the patient is around 74.5, and among all the 8 patients, 5 were males and 3 were females. And the time from the diagnosis of meningioma is almost ranges from 9 to 17 years, except for the first patient, because the patient didn't survive after the first radioactive nuclear therapy. So the localization of meningioma is for few patients it is metastasis, and some patients it is subcutaneous spontaneous lesion. So the WHO grade, among 8 patients, 7 patients has WHO grade 2 tumor, whereas only 1 patient has WHO grade 3 tumor. So what is the treatments that are applied for all these patients? All the patients underwent surgery either thrice or twice, and external beam radioactive therapy, stereotactic radiosurgery, and along with this they have given chemotherapy with Somatostatin and everolimus. So from the time of initiation of this proton radioactive nuclear therapy, what is the progression-free survival that was obtained in this study, and how they evaluated? So they have taken the cranium score. This is the pre-treatment evaluation score. So based on this score only, we will consider that the patient is eligible for PRRT therapy or not. This is a score which will evaluate the somatostatin receptor uptake. If the meningioma doesn't show any uptake, the score is given as 0. If it shows the less uptake, score is given as 1. If it shows the uptake which is equal to or less than the liver organ, the score is given as 2. If it shows the uptake that is greater than liver, score is given as 3. If it shows the uptake that is more than the uptake of spleen, it is given as 4. So usually the cranium score of 2 is an indication to start the PRRT therapy. So again, the WHO grade is same that we have discussed in the patient characteristics. And what is the maximum radionuclide intake, that is max pre-treatment, before treatment, to know whether the patient is having the somatostatin receptor intake. So this is the maximum radioactive uptake for the patients, and this is the cumulative dose that is given after the initiation of PRRT therapy, which ranges from 10.6 to 29.6. Why it is low for the first patient? Because the patient didn't survive for the second PRRT therapy, he died. So what is the best radiological response? This radiological response is assessed on the basis of RANO criteria. So progression-free survival, 2-dimensional RANO criteria. It is basically a group of neuro-oncologists. They have specified some criteria based on the assessment of MRI images. So that is the bilateral dimensions and horizontal and vertical dimensions. And they have classified the disease as progressive disease, stable disease, positive response, negative response, and all. So based on that, they have evaluated, they have given the progressive disease response for the first patient, because the patient died before the starting of second PRRT dose, whereas for all the other patients, it has shown the response of stable disease. So what is from the starting of PRRT therapy, first patient only survived till 2 months. So that is the time. Second patient, it's 10 months, 17 months, 16 months. That is, they evaluated these patients after 10 months after the start of PRRT therapy. And this patient, they stopped only till 12 months and 9 months. And the seventh patient is not applicable. Why? Because the patient didn't report it. And last patient, they didn't reach till 16 months. So after that, they compared the 6-month progression-free survival rate according to the WHO grades in comparison with the literature that is already available. So the first indicates the current case series, that is, they have scanned with 177 Lou dotatate and 8 patients. 1 patient died, so 7 patients included in the analysis. So first WHO grade 1, we don't have any patients, and WHO grade 2, we have 7 patients, and WHO grade 3, we don't have any patients. Next is according to Mither et al., which was the study conducted in 2020. They have also used the same tracer, and they have evaluated only 7 patients. Among them, 2 patients were grade 1 and 5 patients were grade 2. Next is Paragon et al. This study was conducted in 2019, and they have also used the same tracer. Total 5 patients were included, and they cannot assign them to any of the grades according to WHO, so they have given a grade of unknown grade. Next is Receptor et al. This study was conducted in 2016, and they have used either lithium dotate or yttrium dotate. They have taken 20 patients. In that 16 patients, they have given only lithium dotate. 3 patients, they have given yttrium dotate. 1 patient, they combined both. But they included only 19 patients in the analysis because 1 patient died before the measurement of progression-free survival. In them, grade 1, they have contained only 4 patients, grade 2 is 7 patients, and grade 3 is 8 patients. Next is Jester, Galbron et al., which was the study conducted in 2016. They have used only yttrium dotatate. They have taken 15 patients. Among them, 9 patients were grade 1, 2 patients were grade 2, 1 patient were grade 3, and unknown grade was 3 patients. Next is Marinak et al. They also used both traces, yttrium and lithium. They have taken 34 patients. In that, 5 patients were grade 1, 6 patients were grade 2, and 3 patients were grade 3, and about 20 patients, they belong to unknown grade. And Bartolome et al., and they used the yttrium dotatate. In the 29 patients were started, but 1 patient died, so 28 patients were included in the analysis. They have among them 14 were grade 1, 19 were grade 2, and 5 were grade 3. Next is Van Esson et al. This is the oldest study which was conducted in 2006. They used only lithium dotate. Total 5 patients were taken. 3 patients were grade 3 and 2 patients were unknown grade. Next is Kress et al. And Hartram et al. This was a study conducted recently in 2020. And they have used an external beam radiotherapy plus 1 cycle of lithium dotate. In all the before studies, they have used 4 cycles. Here only 1 cycle is used. Total 10 patients were taken. First, grade 1 belongs to 6 patients, and 2 patients were grade 2, and 2 patients were unknown grade. So they have taken the progression-free survival from the initiation of PRRT, and they have compared these results with the results already available in the literature, which was classified according to the WHO grade. So going to the discussion. So the recurrent high-grade meningiomas that cannot be treated with the normal conventional techniques like surgery or radiation therapy, they still remain an unmet medical need in the neuro-oncology. Even though there was recent lot of advances in targeted therapy and immunotherapy, they don't contribute much to the dismissal of this high-grade meningiomas. So their treatment still becomes a challenging property. So going to the physical properties of this 177 luteum, which is used in this therapy, it is currently not yet clear that the 177 lute dota is still active if the tumor mass is big or it progresses to the adjacent tissues. And it is also debatable that if the tumor encroachment is into the closed anatomical structures like cavernous sinus, will this treatment will be efficient or not? And the capacity of this therapy to trigger an anti-tumor immune response, which reduces the tumor burden and stimulate the greater therapeutic response, is another area of controversy, that it will be effectively generate the immune response, which helps in achieving the greater therapeutic responses. So in majority of the aggressive and rapidly progressing meningiomas, the efficacy of this treatment procedure is still debatable. So in this situation, this treatment proposal will have to include a plan for the early diagnosis. That is, we should able to evaluate the meningioma is high grade or low grade, whether it is responding to normal procedures or not, and what is the optimization. That is based on Craning score. Will it be suitable for this PRRT therapy, and what is its effectiveness? So first, after 4 initial PRRT cycles, if the patient is still progressing to the disease, we can treat them with again 1 more PRRT cycle, but that should be considered based on whether the patient is more tolerable to this PRRT therapy, and if you take for 1 more cycle, will the results will show a improved clinical benefit or not. So based on keeping this mind both these conditions, then only after 4 cycles, even we can proceed to the 5th cycle if the patient is progressing to the disease. So in the immunological environment of meningiomas, we will have the general inflammatory tissue responses, that is macrophages, B cells, and T cells. So apart from PRRT, immunotherapy is also emerging treatment. But what are all the drugs that are currently available? They didn't show much effective response. So much more clinical trials are required based on the immunotherapy aspect for meningiomas. So as we told, immunotherapy is also an emerging field. So combining this PRRT therapy with immunotherapy will likely to produce more promising results in aggressive meningiomas. However, it is very important to narrow down the population whom we have to give the combination therapy when compared with the PRRT alone. So the study will conclude that for individuals with refractory or recurrent meningiomas, especially with grade 1 and grade 2, this PRRT therapy may be a potential treatment when given alone, or when, if we want, we can combine with immunotherapy. So at least for a few months, the tumor progression will be stabilized or stopped, and either it is slowed by the treatment. And this treatment is well tolerated. Why? Because many patients survive. So this research has an impact on meningioma diagnosis, that is based on the somatostatin receptor uptake, which was taken in the scan that we done preoperatively. We are able to know that this tumors belongs to the neuroendocrine tumor group or not, so which will help in the diagnosis of meningioma. Next, when the other conventional treatments like surgery and normal radioactive therapy fails, we can introduce this PRRT, which has the effectiveness on meningioma cells, and we can able to evaluate the success of this PRRT procedure in meningiomas. And this treatment, especially in recurrent or refractory meningiomas, how well it is going to evaluate, we can generalize from this study. So if you have any doubts, you can find me at Bharti and Remix.
Thank you, Dr. Bharti, for this informative talk. Now, I would like to open the floor for the audience for the questions. So there is one question from Vijay. Was there any non-target toxicity?
Yeah, non-target. So that's why to avoid the renal toxicity, they are already administering antiemetic corticosteroids and some suppressive agents, because radioactive therapy may damage the adjacent organs. Apart from that, they didn't reported any toxicity on adjacent organs. Preoperatively only they have given some remedies.
I hope, Vijay, you got the answers for the question. So let's wait for 1 minute for any other further questions. Okay, I did not see any further questions in the chat box. So before concluding today's sections, I would like to inform you all about our next webinar. It is scheduled for 21st June 2023 and will be presented by Dr. Nubu. The topic of the webinar is lung adenocarcinoma promotion by air pollutants. That brings us to the end of our CellTalk webinar today. Thank you everyone for your kind attention and time. I hope to meet you all in the next webinar. Thank you.